Good morning, ladies and gentlemen. It gives me great joy to welcome you all today for today's CME, Postgraduate Surgical Training, The Way Forward. Surgical training is a journey from curiosity to confidence, from fear to finesse. Today's CME is designed to help the young surgeons walk that path with guidance, structure, and inspiration. To begin the proceedings, I would like to invite our respected organizing chairperson and the head of the department, Dr. Rajni Kadri ma'am, to give the welcome address.
Good morning and a warm welcome to all our esteemed faculty members, distinguished guests, colleagues, and dear postgraduates. On behalf of the Department of Ophthalmology, AJ Institute of Medical Sciences, it gives me immense pleasure to warmly welcome you to today's CME on postgraduate surgical training. Postgraduate surgical training forms the backbone of shaping confident and competent surgeons. This CME has been thoughtfully planned with the objective of guiding young ophthalmologists in their journey from learning to mastering surgical skills. With rapidly evolving techniques in cataract surgery and beyond, the importance of structural training, positive learning attitudes, and the adoption of new technologies cannot be overstated. We are privileged to have eminent speakers, experienced surgeons with us today. They will be sharing their insights on effective training strategies, the role of wet labs, and modern method of skill acquisition. A special highlight of this program will be the simulation-based hands-on training with the Fidelis system from Alcon. This provides a unique opportunity for our postgraduates to practice and strengthen their surgical skills in a safe and controlled environment. I invite all participants to engage wholeheartedly, share insights, and collaborate to make the most of the opportunities provided throughout this day. I am confident that today's CME will be enriching and memorable experience for each one of you. Once again, I welcome you all for this CME and wish you a productive and inspiring day ahead. Thank you.
Thank you so much, ma'am, for those words and for giving us a meaningful start to today's program. Now, to formally introduce the events ahead, it is my honor to welcome Dr. AJHRC sir, the organizing secretary, who will share with us the vision and purpose behind this surgical training program and what it hopes to achieve for all of us.
Thank you, Dr. Manya. Good morning, respected faculty members, fellow colleagues, and dear postgraduates. It's truly an honor to stand before you today to speak on the most important and challenging aspects of our medical profession, that is the postgraduate surgical training. The idea for this particular CME, basically when we were planning, normally what we do is we have some of the other clinical topics up and everything. But this time we wanted to do something different, and we eventually ended up thinking about postgraduate surgical training, and especially with our Alcon Fidelis being one of the main important things, because nowadays all postgraduate training is happening on Help Me See platform or the IC platform, and the PGs get a first-hand experience of doing surgery virtually so that they can actually respect the actual normal human tissue when they are operating on the patient. So safety comes first when it comes to all these things. So surgery is not merely about acquiring technical knowledge or learning specific procedures. It's an art, a science, and above all, a lifelong journey of continuous learning, refinement, and dedication. As postgraduate surgical trainees, you are embarking on a transformative path that will not only develop your medical expertise, but also shape your character, discipline, and professional ethics. This period of training is intense, demanding, and at times overwhelming, but it lays the foundation for your future as a competent, responsible, and a compassionate surgeon. The very idea behind this CMA was to establish the learning-based system on scientific guidelines that you can practically implement in your surgical training. Every talk today has been thoughtfully curated by our esteemed faculty members whose dedication and experience we deeply respect. Today, I would like to introduce you to the highly practical and holistic approach to becoming a better surgeon, the 10 commandments of surgery as shared by one of my gurus. And let us now explore these commandments one by one and understand their profound significance and surgical training practice. So, keen observation. So, the first and the most important fundamental skill of a good surgeon is keen observation. You must develop the ability to closely observe not only the patient's condition but also the surgical field, detecting subtle signs that can make all the difference in critical decision making during the surgery. Observations sharpens clinical judgment and helps avoid complications. Motor skill development. Now, basically, surgery is more of a skill-based discipline, and beyond theoretical knowledge, a surgeon must cultivate fine motor skills, precise hand-eye coordination, steadiness, and controlled movements. These skills are developed through deliberate practice, repetition, feedback in simulation labs, wet labs, and supervised surgeries. For most ophthalmology PGs, I normally recommend them to strengthen their left hand, because as you keep learning surgery, you eventually realize how important the left hand is when it comes to the surgery. So people start brushing with their left hand, doing their normal day-to-day activity, start writing with the left hand. So there are quite a lot of deliberate things that you can actually start doing to strengthen your skills. Economy of movement and repeatability of steps. So repeatability is very important, and unnecessary movement at every stage inside the eye should be avoided. So each movement should be purposeful, rehearsed, and aimed at reducing fatigue and the operative time while ensuring safety. Mindfulness plays a very important role, and it involves being fully present and aware during the surgical procedure, and which helps in understanding the patient's status and anticipating what might come next. And this helps a lot in reduction of stress as well as maintaining a calm in decision making during the surgery. Visualization of the surgery. Now, this is one of the most important things. What people say is, even before you operate on a patient, you should actually operate in your mind. Before you even think about operating on the patient, you need to plan exactly what you are going to do on the table. So that is one of the most valuable lessons that we learn about visualization, and we need to plan the maneuvers in advance, mentally rehearse complex steps, especially in our case, suppose we have zonular instability, keeping a CTR on the standby, or anticipating any of these things. So visualization is very important. Coming to algorithm of the surgery. Now, when I say algorithm, each one of us has a particular step. So when you are doing teamwork, which comes next, algorithm plays a very important role. So for every surgery, we follow a particular pattern or a step, like how a computer program guides the algorithm, are guided by the algorithm. Every surgeon must develop their personal surgical algorithm and a step-by-step systematic approach to every case. This reduces the variability, improves reproducibility, and ensures no critical step is overlooked, regardless of the case complexity. Physical activity, exercise, and rest. These are very important, and they form an essential part of surgical training in maintaining physical fitness and mental well-being. Long hours in the OT demand stamina, strength, and focus. Regular exercise improves endurance and hand steadiness, while proper rest prevents burnout and sustains mental clarity. Teamwork. No surgeon works in isolation. Surgery is inherently a team effort involving nurses, anesthetists, technicians, and fellow surgeons, and effective communication and mutual respect and shared purpose are vital for smooth operation in the operation room dynamics and better patient outcomes. One of the most important things for postgraduates is performance review. So whatever you operate, record. That is what I keep telling students. Record whatever you're doing. So reflection is a powerful tool for growth, and after every surgery, practice reviewing your performance, have discussions, analyze what went well, what went wrong, what could be improved, and how to address errors or challenges. Feedback from mentors, video recordings, and self-assessment sessions help you grow professionally. And last but not the least, keeping yourself updated with the innovation. So whatever new technology comes, we need to make sure that we are constantly updated with the surgical instruments, devices, and the newer technologies that empower you. And never hesitate to learn and integrate the newer techniques and technologies, and never hesitate to learn from anyone. However senior you become, keep your ego aside. If you think that someone else is doing a better job than you, try to learn. Go talk to them, learn the newer steps, and make sure that you are giving something good back to the patient. So in conclusion, postgraduate surgical training is not just about accumulating knowledge or logging cases. It's about evolving into a thoughtful, skilled, and a compassionate surgeon. The 10 Commandments of Surgery offer a structured roadmap to sharpen your skills, maintain your well-being, and continually expand your capabilities. I encourage each one of you to embrace these principles wholeheartedly, learn from your mentors, practice with discipline, reflect clarity, and never lose your passion for patient care. The journey is challenging, but with the right mindset and approach, it is immensely rewarding. Thank you so much.
Thank you so much, sir, for your thoughts and reminding us what this program truly stands for. We shall now move forward with the first session of the day. Simulation training gives us space to make mistakes, learn, and grow into real surgeries. To rely on bridging crucial Dr. Kamath to please join us at the dais.
Thank you. At the outset, I'd like to thank the team of this CME. Very powerful CME. I would definitely have wanted even, I agree, there's some problems because not many PGs, but I think the YouTube link is there. I hope that should help. But it's a very pressing demand for the day. It's not, my slides which are coming up will be mainly theoretical. So if the postgraduates have some theory question, you can write it down for that. But otherwise, from my own experience, see, ophthalmic microsurgery, apart from whatever Dr. Ajay just told, is one of the challenges is when you are doing your MBBS, you never are exposed to these sort of skills which you get when you are suddenly exposed as a first year postgraduate to in ophthalmology. Okay, I remember our time when about 20 years back when there were not, wet labs were there only in the premier institutes, including in our institute there was only an old microscope to which we used to attach 2 torches and then tie it with the gauze and then practice suturing under it. And there was no structured program. Whereas now if you go to the West, there's a very, very structured program. Unless you have certain number of hours and credits on a simulator or on a wet lab, they certify you, you cannot touch a. We are developing now. I was just discussing with Madam also. Day by day, earlier in India, the concept of wet lab was very prominent because you could just join some assistant and do hands-on steps immediately. But nowadays, patients are becoming lesser. The patients who want to be operated by postgraduates are becoming lesser. Even CAP patients have become VVVIP. They are more demanding than our special ward patients. So, as we are improving, our nation is improving, standard of living is improving, the cataracts are improving, because improving in the sense, earlier we used to get a lot of mature cataracts. Now we are getting all cataracts in the range of 6-12. So we have to upskill, we have to, there's no room for error. So unfortunately, for that, the training is becoming more and more difficult. And fortunately for us, we have got the wet lab and simulation based training, which will help our postgraduates achieve the skills much, much faster than earlier. So when you go to the aircraft, recently there was an article in the paper that Indigo Airlines, they have blacklisted, so the DGCA has blacklisted so many pilots from Indigo because the simulator setting for landing in Mangalore was not good enough. They were working on a simulator which did not simulate the conditions of tabletop or like Mangalore and similar airports. So therefore there was some problem with the retraining. They had to retrain everybody. So it's very, very essential when you're driving for a pilot to have simulation training. Whereas in our place, in ophthalmic surgery, the eye is okay, one eye, it's nothing like that. It's as important as, flying a flight. Only thing is we are dealing with only one patient, but even then that can affect his livelihood, a lot of other implications. So here what happens is, in the West, there are a lot of studies and there are definitely programs which have a stepwise approach to this training before the patient actually meets the patient. Okay, so the challenge of microsurgery, as I just said, there is low tolerance for error due to a small scale of for the ocular anatomy, and the traditional apprenticeship model has its limitations today. So we need to provide a safe, risk-free environment for trainees, and this can be achieved by mainly two things. One is a wet lab, another is a surgical simulator. So this is what I will be talking about today. So what is a wet lab? I am not going to tell you too many things because it's there. You're going to see it in the afternoon. The whole session is there. I would want you to actually practice it and then see for yourself. But it is something which mimics the real operating room. You can do the surgeries on animal eyes, including goat eyes here. Porcine eyes are much lesser. It's available but difficult to get, but goat eyes are very, very easy. Cadaveric eyes, which are not used for human transplantation, because if they have enucleated the whole specimen and then you can use that. And there are high fidelity artificial eyes which are available for, I think, somewhere around 50 rupees. You get an eye. For certain types of procedures, you can use that. The other things are, you have to get used to the surgical microscope, the hand-eye coordination, the position which you are sitting. All these things have to be held. And then, of course, as sir was saying, your hand movements, your left hand, your right hand, the dominance, how you move your hands under that. And if you're doing phaco, it's hand, eye, foot coordination. So you also have to have your foot moving along the same way. The advantages are, it has a very realistic feel. You can feel the tissue. You can see certain problems. You can try complications. Okay, they say there's something called as, buttonholing. So you see when you're doing a tunnel, what a buttonhole looks like. You can make some errors. You can see how your hand position is. You can see what actually happens. What happens if you go with your MVR too much into the cornea? What's the Descemet detachment? You can plan all that and you can actually do all that on a goat's eye. There is scope for error so that you don't repeat it on the actual patient. Apart from that, to some extent, if you use cost effectiveness is written here, but to some extent it is cost effective because you can use refurbished equipment. You can use, what we are doing now is whatever we are using, the single use blades which we use for patients, we just sterilize them and put it in the wet lab. So there are a huge amount of blades which are available there, which the PGs are then using for the goat's eye. Our time it was very difficult to get visco. Now whatever is the remaining visco, we just send it out and then they use it there. So in that way it is more cost effective when we compare it to a simulator. Simulators are really expensive and that is a problem. The problem here, practical limitation, for example, say goat's eye, and I think my postgraduate has made a video which I will be showing here. The practical problem is the goat's eye is not a human eye. So whatever you do and how much more you practice, it's only your hand-eye coordination which you should get, and you should keep in mind that this cannot be exactly replicated in the human eye. Human eye is much more softer than the goat's eye. So there are some limitations, but it definitely helps in getting a hang of it. The other problem here is you cannot have a goat's eye with complication. You can't have there's some things which you can induce, but not everything. You can, inducing a zonular dialysis, inducing a hard cataract or a soft cataract. Hard and soft, to some extent, there are studies which say you can inject different types, different concentrations of formalin and then get that hardness. I have not tried it myself. We do microwave it, but it doesn't work out that well. But some sort of complications you cannot. You have a standard goat's eye. It's only for the initial part which you can help. Mainly it's for your hand-eye coordination. Compared to that, a surgical simulator is much more better. So it's a virtual reality computer-based system. It mimics exactly what you feel, right from the feel to the results which you expect there. You can actually have realistic equipments. You can have an objective assessment. The machine assesses how much more foot pedal you are pressing, how much force you have put in the incision, what would have happened if you go ahead with this, what are the problems in your technique. It flags what are the wrong things which we are doing. So that way you can assess it. From a trainer's perspective, it is very good because you just ask the student to take this module, and in the end of the module, the trainer gets a report card. as to this student has got these flaws, ask him to improve on the hand-eye coordination, ask him to improve on the right hand, ask him to improve on the left hand. All these details will just, basically pop up, which we can then individualize and train that particular person. The second thing is you can do hundreds of surgeries or thousands of surgeries. Day and night you can sit. It's like a video game. You can just go repeat. You can't get 100 eyes for practicing. How will you dispose them? How will you get them? Mutton shop fellow will not give you that much because he has to sell his mutton. He can, only what is remaining there he will give you. He cannot get goat's eye for the sake of the eye. So it's difficult to procure that. Here it is much easier. The plastic eyes which are model eyes which are there are good, but they are not very good. I'll just show you that in the end. Compared to that, the goat's eye is much better. But here you can repeat it multiple times and there is no problem at all. All you need is internet and you require electricity. And you can get some non-technical skills. Like for example, as you are operating, there are some programs which are there which can suddenly induce a error. Say you are doing and suddenly there is a PC rent. Now what will you do? The person standing on the side will ask, now what are you going to do? So how the person will respond. All these things can be tested out on a simulator. The disadvantage of that, of course, is, I'll forget all the other things, it's the extremely high cost. The cost is somewhere around 4 crores for an ICI simulator, single IC simulator. And we were hoping that some GST rebate will be there. That's also not there. So it's very expensive. In the West, it's a norm, but here it is very expensive as of now. So we'll hope that it becomes, with Fidelis probably they can bring it much better. I do not know. So when you compare it overall, both have their advantages and disadvantages, and we need a combination of both to help it out. So there is a particular way by which you can have a more hybrid approach, where in first phase you start off with the simulator, basic hand-eye coordination, skills, all those things they can try. There are some games in which you have to mark the dots or something like that under that, because first time you take a instrument under the microscope, it's very difficult to adjust to that, so you can use a simulator for that. And subsequently you can use for handling the tissue, the wet lab, and then finally you can have complications and other things which are integrated in the simulator with the basic start on the wet lab. So combination of this approach will help in the in this entire thing to help the student learn cataract or other microsurgery in a better way. Future, they say that by integrating both of the two, we can actually have a augmented reality, mixed reality, and we can integrate it with AI, individual person's problems for the individual case complications can be mimicked, as Dr. Ajay just told that before the surgery you have to run it in your mind. Here you can run it on the screen. So you just run it on the screen, you practice the surgery and you expect what are the problems I might get. Then you approach the patient. So it's for patient safety. Overall, the entire thing hinges on patient safety. So patient's eyes cannot, we try to, of course, complications are an unavoidable part. If you don't have complications, means you're not operated. So you have to have, there will be complications, but at least this will minimize the complications. All right. One more, I think they will be trying it here, where if you are having a good SICS and phaco thing, this is apart from all of this, when you're having a SICS and a phaco thing, a phaco program going together, you can use the SICS nuclei. Usually what happens is we remove the nucleus and we throw it out. Keep the nucleus, keep it in a bottle or something. It'll get dry, that's okay. Just keep it there and use that in the animal eyes later on, and you can practice the phacos in that. So that is somewhat a mix of the best way of wet lab. And simulator, if you have a simulator, there's nothing like it. It's always better. Please, Help Me See and other platforms are there which are giving courses. And soon we will be also starting a course which will be much closer to you. So maybe you can utilize that also. So there's a small video about our wet lab which we use. It's been made by my coach, the video. Now, I'm sorry if the videos are having some problem. I'm not very good at stopping these videos. Yeah. So this is the main setup. So we have a microscope. We have a microscope with a foot pedal that is good for the learning the hand-eye coordination. Phaco machine is there. There's the head. There's a stand for fixing the eyes, goat's eyes. It can also, we have another head which is specifically for phaco. This is the other one. Apart from that, all the instrument trays should be there. There's a microwave which, as I told you, the goat's eyes can be microwaved, not much, it will explode. You have to use it very less. Some other people even give intravitreal. Earlier we used to give intravitreal injection, so practice intravitreal injection first, then do the surgery, but that gives a lot of posterior pressure and you can have a run out rhexis and all that. So these are all practical steps which some tips I can give you. So you want to know how a rhexis will run off, intumescent cataract when you are practicing, give an intravitreal injection and then try to do the rhexis. Very, very difficult. Whereas nowadays they are much smarter. They use these microwaves for 4 seconds or 8 seconds, maximum 8. And then with that they are able to do the procedure. Apart from this, there's also simple things like, say the basic things like suture practice, for which there's another microscope there on the edge. And all you can see some IV bottles there on the side. So these are all the pouches which are there, are the remaining solutions which we didn't use for the surgery. Once the surgery is over, we use that, and all the remaining things are used for the wet lab. So apart from that, there's television collections, so they can actually record what they are doing. As he was saying, as Dr. Kudwa said, you have to actually record every procedure, including your wet lab procedure. To keep a tab on whether our PGs are actually doing the procedure, we expect them to record it and then send us a WhatsApp so that we know that, okay, they have operated. And so if then they are graded on that. So you can do various steps, including peritomy, and these are the basic tissue handling techniques, including tunneling. I am not a very big fan of this. When I was doing my wet lab, this goat sclera is a bit tougher. It is better to do a clear corneal tunnel in the goat's eye, which gives you a feel of a human eye. Because this requires a bit more pressure, but this is how some of my other faculty are training my students. So it's not wrong. You get an idea of the orientation of how deep you have to go. Now you're going to keep your hand. And then other things like the injection of the blue and the side port and all that can be done. And then if you have, I think the next one is the rhexis. So all these procedures which are actually done in normal human eye steps, they are repeated or they are repeatable here. So you can actually do the rhexis. All these things have to be recorded also, and you can share it with the consultant for any tips. The goat's eye capsule, if it is not microwaved, feels very much like a pediatric cataract actually. When you're doing a pediatric surgery, it's very elastic. Then apart from this, you also can do phaco. And in the phaco, we can do it in the goat's eye also. But what we have shown you, I just wanted to show you how the artificial eye which is commercially available, that looks like. So it looks something like this. Only thing is when you're doing, this is the other head which we have for attaching for phaco, which has a drain, because otherwise the fluid will keep draining out. So the problem with this is the nucleus is, you get a feel of the nucleus. It's a sort of a plastic material, but you can't do all the steps in that. So there are some limitations. This is artificial eye. It's not a goat's eye, artificial eye. Doing the rhexis and other things here are a bit more difficult compared to the goat's eye. So for some steps here, we can definitely use phaco. So trenching and other things can be done, including sitting position, how you are seeing, and the foot coordination. These things can be helped done with the phaco. Thank you. I think oh my God. Yes, you can go to the. So we are now the one before this, please. No. Can you just close this, the learner SharePoint? Yeah. Can you place my last 2 slides, please? Yes. Yeah. So we are planning or hoping for a center of excellence. That's, I want to show this. This is Mr. Karthik there, who will be helping you out now. So we have a tie-up with Alcon, so they were helping our PGs do the wet lab practice regularly. And he's a fantastic teacher. I think he will be helping you out. He's already setting up the wet lab there. And that's the Fidelis, that's not the Fidelis, that's the IC which we are going to get in Manipal soon. By next month, I think we should be starting the program. At least a certificate course in ophthalmic microsurgical skills will be started by us. So I invite all the medical colleges and all the postgraduates who are interested to apply. And as soon as it's done, we'll be circulating the flyers. So you can come and have a course, even if it is, we want a 2-hour course in the evening from 4 to 6 or something like that, we can tailor make it. So you can come and utilize the services. Thank you.